Welcome in this talk about EEG for prognostication after cardiac arrest. My name is Michel Van Putten. I'm a neurologist, clinical neurophysiologist, working at the Medisch Spectrum Twente and the University of Twente. Now, before I go to the EEG itself in this particular patient category, I'd like to shortly recap some physiology. Shown are two neurons, one on the left and the other one on the right, where neuron A likes to transmit information to the neuron B. And in order for this to occur, neurons must be able to generate action potentials and propagate action potentials and allow a neurotransmitter at the chemical synapse to be released to essentially talk to neuron B. So this is basically what happens. An action potential is generated and transmitted, and at the chemical synapse, neurotransmitters are released. And if neuron B receives sufficient excitatory input, it will on its turn generate another action potential. Now, as most things in life, this doesn't come for free. So we need energy, neurons need energy in order to realize this process. In particular, they need ATP generated from oxygen and glucose provided by the cerebral blood flow. And in many clinical conditions, this process is disturbed, as we all well know. And then a natural question is, what will happen to these processes? Will they all fail at the same time, or will it more be preferentially? Well, it has been shown and found that initially, this process remains intact. Neurons can still generate action potentials, transmit action potentials, if oxygen and glucose are limited or even depleted. But the first process that fails is the chemical synaptic transmission, illustrated here. One of the reasons probably is that the synapse is a metabolic very active structure, the chemical synapse. Brains take about 20 to 25 watts to function properly, and of that energy consumption, the chemical synapse is responsible for about 30 to 35%. So it's a very active metabolic structure and affected by many clinical conditions. Now, what is nice about the EEG, that you essentially have a clinical readout for, amongst others, the chemical synaptic transmission. So basically, you can listen to how well neurons can transmit information to one another. And this makes it an excellent tool, amongst others in the ICU, to be used, as the cortex and the pyramidal neurons are indeed affected by many clinical conditions, including cardiac arrest. To illustrate this, this is a recording, single channel EEG in black and an EKG in red of a patient who suffered from a cardiac arrest, starting here. And this is 5 seconds and another 5 seconds, no change in the EEG. And then after 10 seconds, the EEG slows down. And after about 20 seconds, the EEG becomes flat. And the patient has his eyes open, turned upwards, no response, indeed is comatose at that particular moment. Fortunately, the heart starts quickly soon after, and the EEG restores very quickly, and the patient is responsive again. Now, this is basically a microscopic observation of reversible synaptic failure of mainly cortical neurons. Of course, if this process would be more severe, the duration longer, then other processes may fail too. And in fact, we can divide neuronal damage into 3 categories. One is chemical, synaptic transmission failure. The other one is electrical, loss of membrane potentials, inability to generate action potential. And the third, that typically follows on the first 2, is dysregulation of volume. Neurons will eventually swell, their volume will increase. And if this all lasts too long, it will become irreversible and eventually lead to neuronal death. It's also possible, by the way, that only chemical synaptic, the transmission is disrupted, and that can become irreversible too. Now, this is all reflected in the EEG. For instance, in this recording, which is essentially flat, or these recordings reflecting probably more selective neuronal damage after cardiac arrest. So the EEG is an excellent and very sensitive readout for these processes. Of note, MRI scans are not that sensitive, in the sense that if only chemical synaptic transmission is disturbed in patients with for instance, with a post-synoxic encephalopathy, your MRI scans can be completely normal while there is still significant dysfunction of chemical synaptic transmission. Of course, if cell volume regulation is disturbed, then we will find abnormalities on the anatomical MRIs, in particular the diffusion weighted images. Now let's go to the ICU, and we have a patient after cardiac arrest, and we start recording and assume the arrest has been like 10 minutes earlier, which is very, very soon actually that the EEG has been applied, and this is the recording we obtain. Now this is essentially a flat EEG, so no signs of cerebral activity of cortical neurons. How can we interpret? Well, in fact, this is too soon to be sure what is the origin of the isoelectric recording. And what we typically do is we need to buy time. So if we follow the process as a function of time, then in this particular example, 12 hours after rest, there's some return of rhythms, and 20 hours after rest, there's a continuous EEG, a little bit slowed, but it's continuous. And this is another patient where the EEG also starts with a flat recording 10 hours after rest. It's still discontinuous, and 27 hours after rest, still to some extent, it's not continuous with a lot of slow rhythms. So two quite different scenarios. And as we will learn shortly, this is indeed associated with the outcome, the neurological outcome of these patients. So what are then characteristic EEG patterns that are and have been shown to be associated with particular neurological outcome? And the outcome is in almost all studies defined by the cerebral performance category score. So CPC 1 and 2 is good recovery, at least that is viewed by most. Patients can return to home, perhaps with a little help. 3 is nursery home, 4 vegetative state, and 5 is dead. And most authors and people consider CPC 3, 4, and 5 as a poor neurological outcome. So what are characteristic EEG patterns? Well, actually, there are 4 categories, and 3 are shown here. One is generalized suppression, so the EEG is essentially flat and remains flat. On the other hand of the spectrum, we have the continuous recordings, so brains are on and they generate rhythms as they should do. And then there's a category characterized by synchronous patterns with significant suppression of the EEG, more than 50%. This is an example of burst suppression, and this is an example of generalized periodic discharges. And the 4th category is actually essentially an EEG pattern that cannot be classified in one of these 3. And what has been shown by now is that these patterns are very strongly associated with the outcome of the patient. And that's summarized on the next slide. On the left, we have an isoelectric EEG, which would essentially be our recording if we would record soon enough after the arrest. In fact, in essentially all patients, the EEG will probably be flat soon after the arrest, definitely during the arrest, but soon after probably too. At least that's in the case in the patients who are admitted to the intensive care unit. Now, if the EEG shows recovery towards continuous patterns sufficiently soon after, and sufficiently soon after the arrest is 12 hours, and in this example, we see a continuous EEG pattern, then the neurological outcome of these patients is good. And good is CPC 1 or 2. And the sensitivity of that finding is approximately 50%, with a specificity close to 95-98%. On the other hand of the spectrum, we may have patterns where the EEG remains isoelectric, as illustrated here, or for instance, has shown burst suppression with identical bursts, a very peculiar and pathognomonic pattern in these patients. And then the prognosis is invariably poor, so CPC 3, 4, or 5. And this has been shown in a very large study last year by Barry-Ruiter et al. In about 850 patients of 5 centers in the Netherlands, but also many other groups already before that moment, including ours, have shown that this is very characteristic, that these patterns are characteristic for patients after cardiac arrest and associated with the outcome scores as illustrated here. Let's do a little exercise. This is 4 hours after arrest. EEG recording is essentially flat, only EKG artifact, but this is too soon to make a definite prognosis. This is 12 hours after rest, burst suppression, non-identical bursts, essentially the gray zone, we don't know. 16 hours after rest, burst suppression with identical bursts. This is a burst and this is a burst within channels. They are nearly identical. This is associated with a poor outcome. This is 4 hours after rest in other patients. Essentially a continuous EEG, excellent neurological outcome. And this is 24 hours after rest, still isoelectric, associated with a poor outcome. A few remarks. It's very important to start monitoring early. The later you start monitoring, the less informative is your EEG. And this is summarized in these two graphs. The largest sensitivity and the best specificity is obtained both for poor outcome and for good outcome if EEGs are recorded within 24 hours after arrest. Another issue that has received a lot of attention is the effect of sedation. Sedation does indeed affect to some extent your EEG pattern, but it does not result in a different classification of the EEGs. So, and it has been studied in detail for propofol, and probably it's the same for midazolam, propofol does not affect the reliability of EEG-based outcome predictions in these patients. And that makes that it is absolutely possible, as shown by many by now, to use the early EEG in the first 24 hours after rest for prognostication. Two final remarks. One is a self-fulfilling prophecy. There are fortunately some studies now, amongst others from Spalletti, where no withdrawal of life-sustaining treatment was done, shown that, and he shows that the EEG patterns I just discussed associated with poor outcome are only observed in patients who are either dead or in vegetative state or in nursery homes. And the recent post-mortem study also shows significant neuronal damage in patients with the EEG patterns associated with the poor outcome. And reactivity, and this is one of the last slides, is also an issue that has received a lot of attention. How relevant is that? And this is an example of reactivity. The EEG changes in response to a sternal rub. In essence, there's no substantial additional value for poor outcome prediction using reactivity, and there might be some additional value for good outcome prediction. But most information is already present in your EEG, in the spontaneous EEG. So in closing, continuous EEG within 12 hours after cardiac arrest is associated with a very good neurological outcome. Persistent suppression, synchronous patterns, or burst suppression with identical bursts are all associated with a poor neurological outcome. And with this, you can identify almost 50% of your patients already at a very early stage after cardiac arrest. Thank you very much for your attention.